There is an immense value in a quiet, ordinary day, the simple ability to sit with your own thoughts. But for some, that quiet is suddenly shattered by a chaotic influx of overwhelming sensory noise. This is the reality of schizophrenia. It affects exactly 1 in 100 people, and the onset is strikingly specific. It almost always strikes during a person's late teens or early 20s. This illustrates the dopamine hypothesis. Deep inside the brain, in an area known as the mesolimbic pathway, there is a severe overactivity of the neurotransmitter dopamine. This chemical flood creates the intense hallucinations and delusions known as positive symptoms. This biological storm strikes right as a person is stepping into adulthood. Instead of blooming into their prime, their reality is hijacked by a fly of neurotransmitters, replacing their world with inescapable noise. For decades, the standard medical solution was a class of drugs called typical antipsychotics, like haloperidol. These act as a heavy brake pedal for dopamine receptors. Returning to our model, these drugs bind directly to receptors in the mesolimbic pathway, halting excess signaling and hallucinations. But this creates a severe problem. Patients are often left with negative symptoms, loss of motivation, cognitive decline, and flat emotion. Merely stepping on the dopamine brake is an incomplete victory. It stops the active hallucinations, but it can leave the patient hollowed out. The quiet days return, but the capacity to actually experience joy is missing. The reason for this hollowing out lies in a central paradox of schizophrenia. The brain is not suffering from a uniform, global excess of dopamine. This model compares two regions. While dopamine floods the center, look at the mesocortical pathway in the frontal lobe. Here, dopamine is severely depleted. This specific depletion causes negative symptoms, the chemical reason for lost motivation and flattened emotions. This explains why older, typical antipsychotics fail to restore the whole person. Applying a heavy dopamine brake everywhere in the brain only starves the frontal lobe even further. Solving this illness requires navigating a biological contradiction. A successful treatment must somehow block dopamine in one specific area to stop the noise, while simultaneously boosting it in another area to restore the self. The effort to resolve that contradiction produced atypical antipsychotics, like the drug risperidone. These medications use a completely different approach. Instead of targeting only dopamine, they also block receptors for a completely different chemical, serotonin. In the frontal lobe, serotonin acts as a natural inhibitor, actively clamping down on local dopamine production. By blocking the serotonin, atypical antipsychotics remove that clamp. This chain reaction releases trapped dopamine exactly where it's needed, right into the starved frontal lobe. By selectively freeing dopamine where it was depleted, these medications restore cognitive function and motivation. It is a method of returning the capacity for happiness that once seemed lost. But altering global brain chemistry always carries systemic risks. There is a third major dopamine route to consider, the nigrostriatal pathway, which controls motor function. When medication blocks dopamine here, it triggers extrapyramidal symptoms. The neural pathways controlling movement begin to misfire, leading to drug-induced parkinsonism, or dystonia, painful, involuntary muscle contractions. One of the most distressing side effects is akathisia. This intense, agonizing internal restlessness forces the patient to constantly pace or move, a biological agitation often misdiagnosed as simple anxiety. It is a sharp irony. If the medication is not perfectly calibrated, the drug intended to restore a patient's internal peace can biologically induce a state of inescapable physical restlessness. Beyond movement disorders, there is a rarer, critical systemic risk, neuroleptic malignant syndrome, or NMS. It can strike suddenly, often triggered by a combination of medication and severe dehydration. NMS is an acute physical crisis. A patient may present with a soaring fever, severe muscle rigidity, and altered consciousness. It is a medical emergency requiring immediate intervention to prevent death. Over the span of years, long-term treatment also carries the risk of tardive dyskinesia, permanent involuntary movements. Preventing this requires ongoing observation by a physician, carefully adjusting the chemistry before permanent damage occurs. Treating schizophrenia involves more than a chemical break. It is a vigilant guardianship over the brain's entire system. The goal is to safely guide the patient out of the noise, so they can once again comfortably appreciate the quiet, Tiny Joys of an Ordinary Day.